Okay, here we go. 10, 9, 8, 7, 6, 5. Oh, let me get that screen off there. Got to get the right screen. There we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting from the home of Neurosurgical TV, right close to the beach. Today we have the honor of having Majaz Moonis. He just gave a lecture a couple of weeks ago. He's nice enough to do another one, and the proceedings are going to be run by Ronaldo Ramirez Chacon, a neurointerventionist from Tabasco, Mexico. And I'll let Ronaldo take over. Hello, Ronaldo.
Thank you, everybody. Right now, the Professor Luis he has a health problem. So in the next meeting, the Dr. Luis Lopez Ibor from Spain, he is to present her work. Right now, I have to present my friend and my professor, Dr. Majaz Moonis. He's a highly accomplished neurologist and professor with an extensive career. Professor in the Department of Neurology and Psychiatry at UMass Medical School and practice at UMass Memorial Medical Center. He also serves as the medical director of the Sleep Disorders Center at Day Kimball Hospital, director of the Stroke Service and the Stroke Prevention Program, director of the Stroke Fellowship Program. The topic right now is about the stroke in young people. In summary, young adults with stroke from cerebral embolic generally have a good functional prognosis for independence, but a significant portion will live with a residual deficit, particularly cognitive, emotional, that require ongoing support and rehabilitation. Professor Majaz Moonis, please, you are on the floor. Thank you so much.
Well, thank you, Ray. I think let me see if I can share firstly.
Perfect. Okay, it's perfect.
Thank you. Well, thank you for inviting me to this to give this talk. Basically, I was going to talk about cardioembolic strokes, but with some focus on stroke in the young as well. So, as you know, cardioembolic strokes account for about 20 to 30% of all ischemic strokes, and they're caused by typically different mechanisms originating from the heart. The most important being atrial fibrillation, and other things like atrial thrombi and cardiomyopathy, etc. These are usually very sudden and cause the most disability if not treated properly in a timely manner. Stroke in the young is not an uncommon phenomenon. As you can see, 16% of all strokes occur between 15 to 50 years of age, and the numbers are actually increasing. You can see the same phenomena mirrored in the US as well. The rising incidence is linked to poorly controlled risk factors such as obesity, metabolic syndrome, hypertension, diabetes, and more importantly, increasing substance use. So that's getting to be a very common cause of stroke in the young. And so just distributed, again, strokes in the young can be cardioembolic, and we talked about that. It can be because of arteriopathies, like dissection is a common phenomenon that you see. The others are uncommon. Vasculitis is not that common. And then you have hematological disorders. And as I said, lifestyle changes, which also account for a lot of strokes, because you can see here that, cocaine, amphetamine, etc., are being increasingly utilized and are really something that we start screening for even in the elderly now, when patients come in with stroke, because that's one of the things that is easily missed if you're not aware of it. And then about 25% of all strokes are still cryptogenic, meaning that we still don't know the cause. Okay. So if you break down the cardioembolic strokes in the young, structural heart diseases such as PFO, which is present in 25% of the population, and becomes a very hard, a difficult issue to address, because you don't start closing PFOs on every patient, but you have to gradually eliminate other causes, and we'll come to that in a second. But other things are more straightforward, like atrial septal defect or ventricular septal defect with a shunt, and things like cardiac arrhythmias, cardiomyopathies, and in developing countries, especially valvular heart disease, such as rheumatic heart disease and endocarditis, are important causes, as well as rare causes being tumors of the heart or prosthetic valve thrombi, etc. So risk of recurrence of stroke with atrial fibrillation is about 5 to 10%, which is the highest that you can think of within a year. And it's reduced by treatment to less than 2%. PFO-related strokes are infrequent, and we'll talk about that in more detail later. Other strokes with cardiomyopathy have a 3 to 5% recurrence, depending on what is the degree of left ventricular function, and non-cardioembolic strokes have a 2 to 4% recurrence rate per year. There used to be a time when we used to use heparin a lot. For every stroke that came in, they were put on IV heparin in a hope that heparin would sort of improve the outcome of that stroke. Dr. Fisher and I did this study, and we found that there was no difference in outcome with heparin. The risk of recurrent strokes was not very high in the first 4 weeks, and the bleeding risk was 3 times more with heparin as compared to patients who were not treated with heparin. So this was an important finding for us to say that acute heparin use is not warranted in acute stroke. With atrial fibrillation, there is there's a score called the CHAD-VAS score, which is a tool to sort of estimate whether somebody should be on anticoagulation or not. So if you look at the various components of the CHAD-VAS score, it is age, presence or absence of diabetes, presence or absence of stroke, TIA, or thromboembolism, vascular disease, and sex. So a score of 0 to 1 really poses very low risk, 0.2, and a score of 0, of course, you don't put patients on anything. Score of 1, which has a recurrent rate of 1.3, is somebody that you would consider putting on aspirin and not on anticoagulation, even though they have atrial fibrillation. It's called lone atrial fibrillation. That means they don't have other risk factors, and that as the scores increase beyond 2, you have to think about anticoagulation. And that's where the risk-benefit ratio swings in favor of anticoagulation. Okay. So this is, again, more of the CHA2DS2-VASc score, which basically saying that 0 or 1, 0 to 1 is low risk, and 1 to 2 is intermediate risk, where you may consider anticoagulation, but over 2 in men and greater than 3 in women, you definitely want to have them on anticoagulation because the risk of thromboembolism is very high. And we'll talk about the agents used in more detail. So how did warfarin come into this picture for atrial fibrillation? There were 2 trials done very early on in 93 and earlier on. The SPAF3 trial, which was dose-adjusted warfarin and looked for recurrent strokes in patients, and the European atrial fibrillation trial, which again looked for recurrence. And they both found that the risk of recurrence was reduced by warfarin to 3.4 versus, if they were on aspirin. So the absolute risk reduction found in the European atrial fibrillation trial was 8%, and the relative risk reduction compared to aspirin was 48%. So that set up the very important finding that Coumadin should be used. While heparin is not useful in acute stroke, but Coumadin atrial fibrillation is very useful in preventing recurrent strokes in atrial fibrillation and ischemic strokes. Subsequently, newer anticoagulants were discovered. There were 3 of them that are called 10A inhibitors: rivaroxaban, edoxaban, and apixaban. And then there are direct thrombin inhibitors that act on factor 2, and the drug that was new was dabigatran, right here. So if you look at dabigatran, which was the first drug, which was an oral drug that was found to be superior to Coumadin in head-to-head trials. It's the trade name is Pradaxa in the US. Is a direct thrombin inhibitor with a very long half-life. And the second one was Xarelto or rivaroxaban, which is a 10A inhibitor and has a shorter half-life and has a similar profile compared to warfarin. Edoxaban is not available in the US, but is used in Europe. And apixaban has a very, very favorable risk benefit profile in the sense that it is superior to warfarin, and it is also associated with the lowest risk of bleeding as compared to the other 3. In fact, the highest risk of bleeding was with the dabigatran or Pradaxa. In fact, and in post-marketing areas, it's been now suggested that patients over 80 years of age should not be put on dabigatran because the risk of bleeding is significantly high. So the advantage of these drugs is, of course, they have the fixed doses, and they're dependent on the renal clearance and liver functions. So apixaban, which is the most used direct oral anticoagulant, is dependent on patient's age, weight, and creatinine clearance. It comes in two forms: 5 milligrams and 2.5 milligrams. And if the patient is older than 8 years of age and has weight of less than 60 kgs or a creatinine of greater than 1.5, they would qualify for a lower dose, 2.5 milligrams. While patients who do not have these risk factors would qualify for the full dose, which is 5 milligrams twice a day. Similarly, there are restrictions for edoxaban and rivaroxaban based on creatinine clearance. So they again both come in 2 doses, and the lower dose is used when the creatinine clearance is low, 15 to 50. That's when you use the lower dose. So as we said, there are many choices for non-valvular atrial fibrillation. But for valvular atrial fibrillation or with low ejection fraction related strokes, the choice is still warfarin, because there have been no trials that have supported so far that valvular atrial fibrillation should be treated with the newer drugs, which obviously are more convenient and have the advantage of being fixed dose, no blood testing, and no food restriction. So those are the big advantages of the newer drugs. Sometimes, especially in the older population, you encounter this phenomena called cerebral amyloid angiopathy, which coexists with atrial fibrillation. So if you have somebody with a stroke and you have all of these things that are called cerebral amyloid angiopathy, being the blood vessels that have amyloid deposition in them, it is an issue because the question now is that how do you treat these patients going forward? And this is just a criteria, Boston criteria for defining what is definite cerebral amyloid angiopathy, which is by biopsy or postmortem. Probable cerebral amyloid angiopathy has clinical and pathological features that demonstrated. So there's an evacuated hematoma specimen that demonstrates hemorrhage and amyloid deposition. Probable cerebral amyloid angiopathy also is because of MRI findings of microbleeds, which is what I showed you here. These are called microbleeds, and they're cortical microbleeds. They're not subcortical. So either you have cortical microbleeds or superficial siderosis, meaning that you have subretinoid hemorrhages here, which are superficial. They're not in the sulci, which is aneurysmal bleed. So these superficial siderosis and the amyloid deposition in these blood vessels constitutes the probable amyloid angiopathy. And possible amyloid angiopathy is basically if you have a single bleed, which is cortical. For example, again, here. So if you see somebody like this with a cortical bleed, which is right here, that could be cerebral amyloid. That's possible cerebral amyloid angiopathy, and you would look for it with more detail with the MRI to see if you can see this kind of pattern. Why is this important? Because the usual risk of recurrence after intracerebral hemorrhage, intracerebral hemorrhage after resumption of anticoagulation, is only 2 to 3% per year. The risk in patients who have cerebral amyloid angiopathy is 3 times more. That's 8 to 9%. So now it's a problem. How do you use anticoagulation in patients and not risk a serious bleed again? One of the options is to use what is known as a Watchman device, which is basically putting a corkscrew, which is this is a Watchman device. You put it in the non-invasively through a catheter into the left auricle, left atrium auricle. So you go through a catheter, you puncture the interseptal defect, and you put you plug up this area, which is where all the clots form. And the Watchman device, of course, has been tested in 3 different trials: Protect AF, Prevail, and the Prague 17, and was found to have non-inferiority to warfarin, and obviously offers an option for patients who are who have cerebral amyloid angiopathy. This is a meta-analysis of these trials, pool results, and left atrial appendage closure was non-inferior to oral anticoagulation for prevention of stroke or systemic embolism. So it really offers a very robust alternative and a safe alternative to anticoagulation in these patients who have this problem. The other option could be to use apixaban or Eliquis, as it's called in the US. The drug was shown in the Evros trial to have a much superior risk reduction compared to aspirin in terms of recurrent ischemic strokes, and the risk of bleeding was the same as aspirin. So that's another option in patients who do not want to have any kind of device put in. And there are some patients who would opt for this rather than, opt for a Watchman device. What about PFO? We talked about PFO. The 25% of the population has PFOs in general, right? So there was a time when everybody thought that migraines were related to PFOs, and they were closing PFOs with an occluder device in patients with migraine. And at a certain point, it became so lucrative that everybody was doing it. Whenever they would find a PFO, they would close it with consequences. And because of that, the FDA actually had to come down and say that, you cannot do this. I mean, this is banned. However, there is a place for PFO closure. PFOs account for a certain number of strokes in the young. And we'll define that in a second. But there were 4 trials that were done that compared closure versus either anticoagulation or antiplatelet drugs. And first of all, these were the 4 trials: close, reduce, defense, PFO, and respect. The one thing that they showed was that recurrent stroke versus medical therapy was reduced by 45%. The same thing on the remaining trials. But one disturbing thing is that during closure, you had atrial fibrillation, which was transient in most patients, but could be permanent. So you would end up by closing the PFO and yet having to treat those patients for persistent atrial fibrillation. So that's one of the risks. That's why it's so important to closely monitor, understand why there's a prevention needed or not. And you can see this. So these are again these 4 trials. You can see that they had criteria of number of bubbles that were passing through the PFO in a right to left shunt, and one of them required atrial septal aneurysms also on top of it. And you can see that, first of all, the important thing is that in all of these trials, they could not find enough significance till they followed patients for a very long time. So 6 years for respect, reduce 3 years and close for to almost 5.3 years. So this is what it says is that these are infrequent events. The cardioembolic strokes through a PFO are not this don't have the same frequency or risk as atrial fibrillation. So one doesn't have to rush into closing these things. And obviously, it tells us that if you have to follow patients for such a long time to find significance or no significance, then uh, work them up for other risk factors first before you think of closing a PFO. So again, I wanted to point out that the complications that can occur with closing or occluding the PFO with a device are you can have perforation, thrombus in the heart. You can have pericardial tamponade, bleeding, infective endocarditis. These are uncommon things. These are not seen in good centers where there is a high volume of uh, intervention. But what is really the most important thing is atrial fibrillation. Patients who develop atrial fibrillation. So approximately, if you average this is about 4% patients develop atrial fibrillation during the procedure, and 1% at least has persistent atrial fibrillation when they do develop atrial fibrillation, which means that now you've closed the thing, you also put the patient on anticoagulation, which makes no sense because if they were going to be on anticoagulation anyway, then they did not need a closure because closure is as good as anticoagulation. This is one of the ways to sort of figure out, it's called the rope score, is to figure out how to, what is the probability of a PFO related stroke. So you start from 10 points and you start subtracting a point for each risk factor. So no history of hypertension gets a point, no history of diabetes gets a point. So, and then it's largely driven by age. So younger patients get 5 points. Older patients get, if you're over 70, you get 0 points for age. So if you took a 70-year-old with a history of diabetes, right, and with a history of hypertension, the risk of PFO-related closure, a PFO-related stroke is very low, and you would not even think about it. But if you took somebody who is, who's 30 years old or 40 years old, and has none of these risk factors, the risk of a PFO-related closure, stroke is very, very high. So it is really a disease of the young when it happens, which is why we don't normally consider closure in patients who were over 60 years of age. So what do we do really? If you have a rope score of more than 7, you have a high probability of PFO attributable stroke. And again, like I said, the factors that drive this high score are younger age of the patient, no diabetes, hypertension, or other risk factors, cortical looking infarction, which is what a typical embolic stroke is. It's a cortical stroke, and no prior history of stroke or TIA. So these are the factors that drive a higher rope score and suggest that the PFO is probably the reason why they had the stroke. However, you have to still monitor these patients with a heart monitor for 30 days to make sure, at least for 30 days, to make sure that they do not have atrial fibrillation. Because if they have atrial fibrillation, they will be on anticoagulation. And if they're on anticoagulation, they do not need a closure. Similarly, you work them up for hypercoagulable states. And there's a whole panel of blood tests that need to be done to rule out hypercoagulability. Because if you have hypercoagulability again, you would be on anticoagulation and do not need a PFO closure. If you do a bubble study of the heart with the echocardiogram with the bubble study, and you find that there are 20 bubbles and there's atrial septal aneurysm, etc., and you find there's a high probability of this, then at least in our center we do a Doppler scan of the legs and a CT angiogram of the abdomen and pelvis to make sure that there's no current need for anticoagulation. PFO might be related, it is a different issue, but then you would start them on anticoagulation if you found any of these as positive, because that's something that requires immediate attention. These are the devices that you use: the Implicit device, the Gore cardioform septal occluder. Like I said, the pre-procedural risk of atrial fibrillation is 1%, and once you close this device successfully, you put patients on a dual antiplatelet therapy for 1 to 6 months, and then switch them to aspirin alone, and do a follow-up echocardiogram to make sure that the seal is firm and there's no further leak from the PFO. And these are the results of the pooled meta-analysis of all the trials, which showed that all-cause hemorrhagic strokes were reduced with aortic closures. Major bleeding was much lower because you're not using anticoagulation now. Unexplained deaths were lower because, again, you're not using drugs that, and all-cause mortality was reduced. Moving on to a third category of embolic strokes, which are called embolic strokes of undetermined source, which is basically defined as embolic strokes, but not lacunar strokes. That means they're not in the brainstem. The brainstem strokes are usually lacunar strokes. And there's no cardioembolic source after prolonged monitoring. In absence of any large artery, it's a sclerotic disease. So if you exclude all those things, and you exclude other causes of stroke, then these would be classified as embolic strokes of undetermined source. And these strokes are the ones that are the most problematic, because we treat them with best medical treatment, which includes high-dose statins and aspirin or other antiplatelet drugs, and monitoring the risk factors and managing the risk factors. But we still don't know why these patients have strokes. However, before I go to that, with prolonged monitoring, when which we do routinely in these patients, we have a small device that can be placed subcutaneously, and it basically monitors the heart rate, the heart rhythm, and with a battery life of 3 years. So it really has enough time to monitor every month. Every month the data is downloaded, and what has been shown in with prolonged monitoring is that ultimately these patients do show up as atrial fibrillation, and lot of these patients end up showing atrial fibrillation. And when they do, you switch them over from an antiplatelet drug to anticoagulation. Okay, so, but without evidence of anticoagulation, if you see this kind of patients and you do a blind anticoagulation, there were 3 trials that looked at the 3 different drugs, so this was a trial that was done with rivaroxaban versus aspirin in patients with the embolic stroke of undetermined source, and it was found that it didn't make any difference. They both had the same event rate. So obviously this blind treatment is not protective, and it's not encouraged. Similarly, the risk for major bleeding was much higher with the anticoagulation as compared to aspirin. So for now, the treatment, the option remains aspirin, not anticoagulation, till you find that they have atrial fibrillation. Other trials have been done with dabigatran and apixaban, Respect ASUS and Arcadia, which looked at atrial cardiomyopathy and arteropathy, and found both these trials actually were negative too. So now we've tried 3 different drugs with different kind of inclusion criteria in patients with embolic strokes of undetectable source, and you find that all 3 trials have the same results, that the anticoagulations with various new drugs is not protective in these patients. So at the moment, till you have atrial fibrillation in long-term monitoring, you would not change your options to anticoagulation, even though it's kind of frustrating. In the option, you always feel like, you should anticoagulate these patients. But with 3 trials being negative, there is no point of thinking about anticoagulation here. So these are some of the rare causes of cardioembolic stroke, which are getting more common now to some extent. Firstly, merantic endocarditis, which is basically a paraneoplastic or a rheumatological disease where you have thrombus formation on valves that are thickened. So that can be a source of a stroke. Second one that is getting more and more common now is bacterial endocarditis, and in any major hospital you would see in a month at least 3 or 4, two or four cases. I think largely because of the poorly controlled risk factors, and secondly because of overuse of antibiotics for minor issues, which is developing resistance and causing this. The third one is left ventricular thrombus. You have cardiac myxomas, prosthetic valve thrombosis. And then, very interestingly, if you don't find any of the cardiac issues, you may find that there's ulceration of the aortic arch. If there's aortic arch ulceration, it can also cause a cardioembolic looking stroke. And it's usually defined as complex plaques which are unstable, which are more than 4 millimeter thick in thickness, and they can embolize to any part of the brain. And the treatment for that is controversial, but some people prefer DAPT for six months or a year. Some people prefer to have them on anticoagulation for 6 months. So this is the table I put together, which just says what are all the things that we listed in the last slide. So for merantic endocarditis, you have to treat the underlying malignancy or the vasculitis, like lupus or whatever else is going on, right? And in these patients, therapeutic anticoagulation is considered if they are not contraindicated. Once you know that this exists, you want to start treatment as soon as possible, because to prevent further strokes, and avoid surgical intervention, because you might have to then replace the valve completely, and the problem might recur if it's because of malignancy or because of anything else. For infective, I'll talk about this in more detail separately. So let's skip that. For left ventricular thrombus, which is very apical thrombus, if there's left ventricular apical thrombus with hypokinesis, there is a very high risk of having an embolic stroke. These patients should be on full anticoagulation with either warfarin or with the direct oral anticoagulants urgently. and you should follow these patients for at least 3 months on these antibiotic on blood thinners, and make sure that the thrombus is resolved or the problem is resolved before you take them off it. And of course, if they develop atrial fibrillation in the meantime, then it is permanent. You need to continue anticoagulation for life. For atrial myxoma, surgical excision, prosthetic valve, IV heparin immediately, and then warfarin long term. For aortic arch, as I said, aspirin plus clopidogrel is the preferred treatment. And some people, some folks prefer to anticoagulate them if there is a large mobile thrombus, along with high dose statins. Other ones are catheter related. We talked about that, and for PFO related, we've talked about the management that you do DAP for 3 to 6 months, and then after closure. And then you basically switch to a monotherapy. So this is diagnostic criteria for bacterial endocarditis, the modified Dukes criteria. You have to have positive blood cultures usually with the staph, the strep, or enterococcus, the usual organisms. There's echocardiogram evidence of vegetations in the heart, in the valves, and there could be predisposing conditions like underlying heart disease or IV drug use, which is very, very common as a cause. So you can either do a transthoracic or transesophageal echocardiogram to look for vegetations or abscesses, and look for mycotic aneurysms that can form in the brain with CT MRI with contrast to see if there's enhancing lesions. And you might even have to do an angiogram on these patients to make sure that there is no mycotic aneurysm. Because one of the things about this is that if you have a ischemic stroke in these patients, you're stuck in a very tough spot, because anticoagulation in the presence of mycotic aneurysms is asking for trouble. Because if they have mycotic aneurysms, they'll rupture. Very likely they'll rupture. And that's what limits your option to something else. That's why you cannot use anticoagulation here. So empirical therapy, of course, treating the blood cultures with whatever antibiotics. There's the usual choices of antibiotics, and you treat them with antibiotics for 4 to 6 weeks. And if there's persistent bacteremia, or if there is, if there is persistent bacteremia or the vegetation persists, you might consider early surgery to reduce mortality and embolic complications in selected patients. If there are fungal infections, they're very hard to eradicate, and you might have to require a surgical intervention with valve replacement. So it's a multidisciplinary approach. You have cardiology, infectious disease, neurology. All of us are involved in this, in the decision making in this process, and it is a tough thing to treat, because if you have mycotic aneurysms, you really want to get rid of the source as soon as possible, so that you don't necessarily have to resort to anticoagulation. And sometimes you have to, but if you do, there's a very high risk that you'll cause intracerebral hemorrhage. The mortality is about 20% despite advances. Early surgical intervention in complicated cases improves the outcome. Recurrent embolic strokes risk is reduced with early surgery. And again, there should be multidisciplinary shared decision-making approach. So tailoring therapy, basically most patients are treated with antibiotics, IV antibiotics for 4 to 6 weeks. And in that process, as long as the thrombus is getting smaller and or resolving, you don't necessarily have to go to surgery. But once you have, if there's no non-resolution, then you have to go for early surgery. My last slide, I'm just summing it up, that cardioembolic strokes are the most devastating ischemic strokes. Atrial fibrillation is the most common cause, which is accounts for 50 to 60% of these patients. Anticoagulation, either with warfarin or with a direct oral anticoagulant therapy, are good. When we do surgical intervention, for example, the MACE surgery or something else to abolish atrial fibrillation, you just reduce the risk or reduce the frequency of atrial fibrillation episodes. You do not abolish it. And patients who after these surgical procedures are left without anticoagulation end up having a stroke at some point. So our approach is to always continue anticoagulation even after the surgery. Because surgery is just going to reduce the risk of very frequent atrial fibrillation. Patients with cerebral embolic angiopathy will benefit from Watchman device in terms as opposed to long-term anticoagulation because the risk of bleeding is high. PFO closure in appropriate cases reduces recurrent ischemic strokes. And of course, early management of bacterial endocarditis can be very life-saving. Thank you very much. And that's my last slide. And I can stop share at this point.
Very good. Ronaldo?
Thank you so much, Professor. Very impressed. Any question about our audience in this meeting?
Don't be afraid. We don't have a big crowd here. Don't be shy.
Okay, I have a question. Professor, what do you think about the endovascular treatment quickly as possible when the clot is into the great artery?
When the clot is in a large artery?
Yes, regardless the cause. When the clot is in the great artery, I think the endovascular treatment is similar.
Absolutely. Absolutely.
And you seen in the treatment with the medical and endovascular treatment, or what do you think? What is better, to begin with the medical treatment or the combination?
So the combination is, there was a recent trial that actually showed that the combination is actually better than direct thrombectomy because the reason for that is there are two things. Firstly, now we are using TNK. We are not using alteplase. We are using TNK, which is cheaper drug, longer half-life, and can be given as a single shot, single bolus, right? So it takes 1 minute to do this. It doesn't take a very long time. So that's the one thing. The second thing is that in this trial, it was shown that patients had a better outcome if they were given thrombolytic therapy plus thrombectomy or aspiration, as opposed to patients who went direct to thrombectomy. I think one of the main reasons is because after removing a clot, you do not treat the distal emboli. What happens is there's a shower of tiny emboli even after removing a clot that actually block the distal vessels, and that's why there have been trials that have shown that you can give intraarterial TPA after embolectomy to try to improve. There were two trials in the International Stroke Conference that were tried, that you can give a small dose of intraarterial TPA to try and improve the outcome. And similarly, the same thing would be applied to the TNK, because TNK would help to try and reduce the complications of distal emboli. Not it will you can remove the clot, but the clot removal is not the only solution. You need both.
Oh, okay. Thank you, Professor. In summary, the prognosis for recovery and improvement following a ischemic stroke to a cerebral embolism in young adults is general for me considered more favorable than for older patients. However, full recovery is no guarantee, and significant challenge remains. I think it is true.
True. I mean, the recovery depends on a lot of factors. It depends
Yeah,
on how much damage has been done, what is how old the person is, how much what are the comorbid conditions. The most devastating ones are diabetes and hypertension. So people who have untreated hypertension, uncontrolled diabetes are the ones that really do badly. Even with you can remove a clot, but you can't remove the disease, which has already happened.
Yes. All right, Professor. I mean, it depends of the cause, no?
Yeah,
It
of
depends
course.
on the cause, of course. Thank you, Professor. Any question? Our audience, don't be shy, please. The professor has a great experience in this topic.
Okay, I guess thank you very much, Dr. Moonis.
All right, thank you.
Appreciate the time you took. Thank you. Okay, Ronaldo, you're going to make a small presentation. You mentioned something.
Okay.
Yeah. Let me introduce you, Ronaldo. Ronaldo Chacon, he's a neurointerventional radiologist from Tabasco, Mexico. Welcome, Ronaldo.
Thank you, Professor. I don't have presentation, but maybe in another meeting, Dr. Luis is right now he's with some health problems.
I'm sorry, Lou. I put you on the spot. I thought you mentioned that. I was wrong. Okay. Well, anyways, thanks everyone for coming. We have this webcast every 2 weeks. And
yes,
we have Fitri here. Fitri Santiyanti, you want to say hello, Fitri, or are you off the camera? She's an anesthesiologist from Indonesia that has an interest in
Hello, John. Hello, Dr. Ramirez. Hello, everybody. Yes.
I think you may have met Dr. Moonis when you were in Spain.
Yeah, thank you for
5 years ago.
always
5 years ago. Do you remember? You remember Fitri, Dr. Moonis?
I'm sorry?
Do you remember Fitri?
Yeah.
Oh, okay. Very good.
Thank you for a good lecture today, Professor. And thank you, John and Ronaldo, to always invite me in this meeting. Where is Luis today?
I'm sorry?
Where's Lois?
Oh, Lewis is feeling ill, I believe. So he just called, but we'll be showing him the webcast, and hopefully he bounces back, and we'll be here in 2 weeks. We hope everybody comes here in 2 weeks. Okay, everyone. Thank you very much.
Thank you very much. Bye now.
Bye-bye.
Thank you, Fitri. Bye-bye.
Thank you. Bye-bye.
Bye.